Welcome to the 52nd in a series of monthly sessions. Today on February 23rd, a fantastic session awaits us. I'll introduce the speakers in a second, but today we're going to talk about the orbit and why neurosurgeons really need to understand and master the orbit. After our esteemed speakers will finish, we'll have our cerebrovascular and skull-base fellows. First, Matthew Sun present a case, and after that, our infolded fellow, PGY4, Eva Wu, present a second case. Of course, all of you are probably have been on these sessions many times. These are some links if you are interested in contacting us here at the University of Miami, or particularly if you're interested in viewing the previously recorded sessions. We have now a treasure of multiple speakers that have given fantastic sessions over the last 3 years. Anytime during the session, if you have questions, please put them in the Q&A box and we will address them at the end. Again, I am very pleased to have as co-directors, as you know, Carolina Benjamin, my partner, Mike Ivan, and Bobby Stark. So now for our speakers tonight, I'll introduce them in the order in which they are going to speak. First is Maria Perez-Selda, who is an associate professor of neurosurgery at the Mayo Clinic in Rochester. I don't think Maria needs any introduction to this audience. Not only is she a spectacular, accomplished skull-base surgeon, but of course a Roten student and has recently opened a fantastic Roten anatomy lab at Mayo Clinic and has fantastic courses, and of course has produced beautiful dissections over the years. She's going to talk to us about the orbital space, a route and a destination for the neurosurgeon, a surgical anatomy roadmap. Next will be Chris Moe. Chris is professor of otolaryngology and at University of Washington in Seattle. Chris is an absolute pioneer in orbital endoscopic surgery and has focused his attention on that. When I was president of the NASBS several years ago, he was the first one I thought of to encourage, to expand the oculoplastic theme within NASBS, and of course it has taken off since he has put his effort there. And Chris, thank you very much for introducing that field, particularly to us, the neurosurgeons. And last but not least, Georgios Zenonos, who is an assistant professor of neurosurgery and co-director of the Center for Cranial-Based Surgery and director of the cranial nerve program, director of clinical operations in Pittsburgh at UPMC in Pennsylvania. Of course, I'm biased. George was one of my spectacular skull-based cerebrovascular fellows a few years ago. And George is going to talk about dancing around the optic nerve. George is Greek, so I'm not sure if it's a Zorba, the Greek dance, or not, but we will see. Indications and limitations within the surgical toolbox. So there we go. Enough of me talking. So now, Maria, please share your slides and start your presentation.
Thank you very much. You hear me okay?
Yes.
Thank you very much for the invitation. It's really a pleasure to talk here about the orbital space, which is a route and a destination for the neurosurgeon. And I'm going to talk mainly about, the anatomy and how different approaches and different routes, can be used in our surgical toolbox. And this is a superior view where we can see the orbit on the left side, and we know that from the superior, from the transcranial standpoint, we can really access very well the roof of the orbit and the lateral aspect of the orbit. And then at the same time, we see here that the nose and paranasal sinuses have opened a new route where we can access, the other medial and inferior half of the orbit from the endonasal standpoint. So two approaches, complementary and really important to know. And we have here, this is the right orbit where we have the orbital rim. This is the supraorbital notch, which is going to be important for our incisions for the supraorbital approaches. And then in the medial aspect, we have the upper portion of the maxilla and then part of the frontal bone joining here anteriorly. Then we have the lacrimal bone, the lamina papyracia, that is part of the ethmoid bone. The roof of the orbit is mainly formed by the frontal bone. And then we have here a great part of the orbit also formed by the lesser wing and the greater wing of the sphenoid. Here, the maxillary, the upper part of the maxillary sinus, part of the maxilla, and a little bit of the palatine bone also forming the orbit. Then we have also forming the orbital rim, the zygomatic bone. And just to look at the important structures that we are going to review, we have from lateral to medial, the superior orbital fissure that continues with the cavernous sinus, the inferior orbital fissure, the infraorbital groove, and this is the infraorbital canal. And then we have very important, the optic canal right here, and this is the optic strut. We have two foramina that are very important, the anterior ethmoidal and the posterior ethmoidal foramen, that are really key for some of the approaches. So looking straight at the orbit, again, a great part of it is formed by the greater wing of the sphenoid, lesser wing of the sphenoid, and in between them, the superior orbital fissure. So the approaches to the orbit can be divided between the approaches to the orbit itself or the approaches through the orbit to either the cavernous sinus, the frontal lobe, the optic canal, etc. So this is a view of the sphenoid sinus where we can see, this is an anterior view, this is the sphenoid bone and the sphenoid sinus here. So this is the optic nerve in the optic canal. So great part of the optic canal is facing the endonasal surface, and the roof is formed by the lesser wing of the sphenoid and the lateral aspect by the optic strut. Then we can see the relationship between the superior orbital fissure. And if we build the skull base from posterior to anterior, we see the sphenoid bone, and this is the ethmoid bone, which is going to dictate our medial approaches. Just to look at another perspective of this anatomy, it's important to know that the external part of the orbit is covered by the orbicularis oculi. And very importantly, the branch of the orbicularis, which is about more or less about within the 2 centimeters behind the external canthus. So we want to make sure that when we perform these incisions in the anterior part of the septum or the orbit, we are not injuring the facial branch to the orbicularis oculi. So this is another view of the same dissection, the relationship between the facial nerve branches and the orbicularis oculi. And if we dissect it further from lateral to medial, we're going to find the orbital ring, the external aspect that continues with the zygomatic arch. And the relationship between the orbit, the temporalis fossa, and the temporal dura is very important, as we are going to see. So if we remove the orbital rim and then we drill part of the sphenoid wing, we're going to find the periorbita. And then this periorbita, if we remove the periorbita, we can see from lateral to medial, the lateral rectus muscle, the superior rectus muscle, this is the optic nerve, and this is the inferior rectus muscle. This is the levator palpebra and the lacrimal gland. This is the lacrimal nerve. So we have a window from lateral to medial between these muscles to access the contents of the orbit. So again, if the relationships between, this is the orbital apex, this is from lateral to medial. So this is the left side. Lacrimal gland, which is the upper external corner of the anterior part of the orbit, lateral rectus muscle, and then the relationship between the temporal dura, the sphenoid wing that has been partially drilled, that will bring us to the anterior clinoid process, and the relationship between the apex of the orbit, the temporal lobe, and this is the temporalis muscle. So this is a very important relationship, because if we go back, then in continuation with the superior orbital fissure, we see the cavernous sinus. So this is the third cranial nerve that divides into two inside the orbit, is inside the annulus of Zinn. And then we can see, so 6 is right here, so we don't see it very well, but it goes to the lateral rectus muscle here. This is the fourth cranial nerve and V1, which are actually outside the annulus of Zinn. So if we look at the periorbita, they are going to be these two nerves, the branches from V1 and the fourth cranial nerve are going to be just under the periorbita. So we have to be very careful, and if we transcranially stimulate and we are monitoring for, we consistently will see that at the end of the optic canal, we're going to find crossing over the apex of the orbit, the fourth cranial nerve. So this is from an inferior view of the orbit, where we can see, so this is the right side, so this is medial and this is lateral. And then we can see the medial rectus muscle, the inferior oblique, the inferior rectus muscle. And then we can see the optic nerve right there, and the branches of the ophthalmic artery, two of which are going to go through the posterior and the anterior ethmoidal canals. And this is an inferior view of the central retinal artery, which is a branch from the ophthalmic artery and goes consistently in the inferior aspect of the optic nerve in its orbital segment. So now switching to the superior aspect, we have here the frontal sinus. This is the ethmoid and the sphenoid sinus, and then we're going to open the roof of the orbit and opening the periorbita. So the first thing that we're going to see is the frontalis, the frontal branch of V1, and then this is the trochlear nerve, the fourth cranial nerve. And then we see that the third cranial nerve goes inside the annulus of Zinn and divides in two main branches to innervate the rest of the muscles. This is the superior ophthalmic vein that also runs here, very important. This is the lacrimal nerve. And we can see that this is the lateral palpebral muscle, and we see the superior rectus muscle, the superior oblique muscle, and we can see the trochlear nerve innervating the muscle here. So then looking at the superior and inferior aspects of the divisions of the third nerve that we can see now again from lateral to medial. Very important to remember that the superior orbital fissure is in continuation with the cavernous sinus. Here we see the sixth cranial nerve that we didn't see very well in the previous dissection, with further dissection of the cavernous sinus. And how, if we divide the lateral rectus muscle, we can see the superior and inferior division of the third nerve. This is the ciliary ganglion with its branches. And we're going to see also the ophthalmic artery that at some point will give off the central retinal artery that we don't see in this picture. This is just a close-up view. Once we open the annulus of Zinn, the extra annular components. So it's the trochlear and the frontalis branch of V1. And then we see the intra-annular components that are here below, which are the rest of the cranial nerves. So again, a superior view, this is going to be important, the supraorbital nerve, which is going to also dictate our extension of the supraorbital craniotomy. And if we go from anterior to posterior, this is the right orbit, and we can see the orbital septum and the superior tarsus, the inferior, and the orbicularis oculi that has been divided on the external aspect of the orbit. So this is the eye, our lacrimal gland, the medial and lateral canthus and the ligaments, superior oblique, inferior oblique, and the relationship with the infraorbital nerve and the orbital vein that is right here. So several different incisions that can be performed in the eyelid crease, in the eyebrow, and in that case we need to be lateral to the supraorbital nerve, and we can palpate the notch in the orbital rim, and we can also perform like lateral canthus incisions, and also we can access the inferior and medial aspects of the orbit, as we will see. So this is an eyelid approach, and we can expose the orbital rim. And if we use the endoscope to look at this approach, this is the orbital roof, this is the periorbita, and we can see the anterior ethmoidal arteries. So we are right here looking at the right side of the orbit, and then we are going to see the superior orbital fissure, and this is the meningoorbital band, and is in continuation with the superior orbital fissure and the cavernous sinus, and we can even expose the optic nerve in the optic canal. We have here the frontal lobe, and we have here the superior orbital fissure and part of the anterior clinoid process. So we can go as far back, and this is all through the orbit, drilling the orbital roof. Other kind of incisions that are not technically through the orbit are just supraorbital. For instance, like an eyebrow, we can also do an eyelid incision, but this is like a supraorbital craniotomy. We want to be medial to the supraorbital nerve, and this is how it looks like after we drill the surface. We can retract gently the frontal lobe, and this is really like a great view through that approach, assisted with the endoscope, of the optic nerve and the carotid artery. This is the third cranial nerve, and this is the tentorial edge. This is another view, better looking at the chiasm. So we see the optic nerve in both sides. It's a great view and great approach. We can also do a transcaruncular approaches, and this is a medial approach where we divide the soft tissue here, and we're going to see basically the anterior and posterior ethmoidal canals, and this is a view of the lamina papyracea. So we are in the medial aspect of the orbit. If we drill, we can see clearly the mucosa of the ethmoid cells and the labyrinth. And what if we open inferiorly through a subconjunctival approach? We can access the inferior aspect of the orbit that we said that was related to the infraorbital nerves. And if we drill that, we can see the infraorbital artery, the infraorbital nerves, and this is the roof of the maxillary sinus. If we perform an incision externally here in the external canthus, then we can, either with this incision, an eyelid incision, or even an eyebrow incision extending laterally, we can really dissect the lateral orbital rim, and this is the joint of the sutures of the zygomatic bone, the frontal bone, and this is the sphenoid bone, the greater wing. And through here we can perform an osteotomy laterally, which corresponds to this aspect here. So then we are going to find the meningoorbital band here with the superior orbital fissure. So if we dissect, this is the lateral aspect of the orbit, and if we drill, we go through, we will follow towards the sphenoid wing, and we are going to have laterally the temporalis fossa. So this is the temporalis muscle. Here we can see very nicely the temporal tip of the dura, And if we follow, so we are right here. If we follow this dissection, we can look at the floor of the middle fossa, and then we can follow towards the cavernous sinus, which is a great approach for it. And then even Meckel's cave, this is V2 and this is V3. And here we'll be looking at foramen spinosum with the middle meningeal artery, and this is foramen ovale with V3. So really a great approach for intracranial pathologies, for cavernous sinus biopsies sometimes, for even trigeminal schwannomas. And then our endoscopic endonasal approaches really opened a new window into the orbit, orbital apex, and optic nerve and optic canal that are going from medial to lateral. We already talked about the ethmoid labyrinth. We talked about the lamina papyraceae and how it joins here and forms the orbital apex and the optic canal posteriorly, the medial rectus and the inferior rectus muscles, and then the main window that we have to operate on intraconal pathologies, which is between these two muscles. Sometimes we can go lateral to the inferior rectus muscle. We have here the infraorbital nerve, and that's really like basically most of the times our internal lateral landmark for endoscopic endonasal approaches to the orbit. And we're going to see, this is a classical depiction of the optic canal, the carotid artery, and the sella. And looking at the optic nerve in the optic canal, this is the carotid artery. Once we remove, and Dr. Zenonis is going to talk about that in detail, if we open the dura, we can see that the ophthalmic artery really has different patterns, and sometimes it's really medial and superior. So we have to be very careful when opening the dura here, or resecting dura for tuberculomangiomas, not to injure the ophthalmic artery. So this is the most dangerous pattern of for endoscopic endonasal approaches, but it can be medial, can be inferior, or can be inferolateral, like in this other specimen. So this is a view of the ophthalmic artery. This is the classical view of the endoscopic endonasal of the cavernous sinus. And if we look at the anatomy of the exposure of the orbit and optic canal, we know that these are the ethmoid labyrinths, and we can see the lamina papyraceae, can see the skull base and the sphenoid sinus. If we remove the lamina papyraceae, we find the periorbita, and this is the orbital apex and the optic canal. There's an angle between the optic canal and the main axis of the orbit that goes this way. Is not a straight line. So we can see that angle here is the orbital apex and the annulus of Zinn. So opening the periorbita, removing the fat of the orbit, we see the optic nerve here, and this is the medial and inferior rectus muscles. This is the main window to work from the endoscopic endonasal perspective. And here we are seeing the central retinal artery, which is essential to preserve. And this is an inferior view with a 45-degree endoscopes of this central retinal artery. So we see the inferior aspect of the third nerve here, and here working lateral to the inferior rectus muscle. And this is a final overview of the anatomy. And for instance, just to illustrate the surgical anatomy of this, a classical case of a cavernous hemangioma, and a very quick video to illustrate the anatomy. So we divided in this case the middle turbinate, and then opening the sphenoid sinus, the ethmoid sinus. So this is the skull base, lamina papyraceae, opening the periorbita exactly in the inferior medial corner. And then, of course, we see first the orbital fat. And we start to dissect between the inferior and medial rectus muscles and start extracting and dissecting the hemangioma. And then just, this is the final view. And this is the postoperative CT scan. So this is mainly what I wanted to talk about, 360 degrees around the orbit from the transcranial, endonasal, and transorbital standpoint. Thank you very much, and I'll take any questions. These are dissections performed by our fellows and by myself as well, some of them, and also with Dr. Yoshioka Fumitaka, some of his dissections. Thank you very much.
Thank you, Maria. This is, of course, beautiful. And let me see if there is any. Maria, unfortunately, has to leave to the OR, so she's not going to be able to stay with us. And all I can tell you is Nima Amini said fantastic and clear. I guess, thanks, Maria.
Thank you very much.
Bye, good luck.
Bye.
Chris, why don't we have you next?
Great. And is everybody able to see my screen now and hear me?
Yes, we hear you. Yeah, perfect. You're good.
Fantastic. I'm going to be talking about orbital surgery, what a neurosurgeon needs to know. And I want to thank you for the invitation. Dr. Marcos has done more than any other person to bring transorbital approaches into mainstream skull-based surgeon and encourage the participation of ophthalmologists and otolaryngologists in the Skull-Based Society. And I also have a number of friends who are ophthalmologists and otolaryngologists at University of Miami who are fantastic people. No disclosures related to this presentation. So when I was nearly finished with the presentation, I thought I'd have a little fun and put into ChatGPT, what should neurosurgeons know about orbital surgery? And it was actually pretty fun. First thing is a thorough understanding of anatomy and physiology. Know the approaches in of the orbit and adjacent structures, understand the pathologies, know imaging techniques. Now here's a good one, be able to collaborate effectively with ophthalmologists and otolaryngologists. Work together to develop a treatment plan that addresses a patient's unique needs and be committed to learning the latest advances. Well, I've outlined in green the ones that I'm going to be covering today, and I'm not going to cover anatomy very heavily after that excellent presentation that we had. But in terms of surgical planning, what is the ideal pathway? To quote Julius Caesar, quid pretium, which means at what price? And that's one of the main criteria we should be thinking about. These procedures should be minimally disruptive, but appropriately invasive. Whether a lesion is a skin cancer or a brainstem lesion is not the choice of the surgeon. And so invasivity is not up to us. The pathway should be short and straight. They should allow comfortable instrumentation. They should allow 0 or 30-degree angled viewing, minimal brain retraction, and an excellent optical cavity. So you need to think about retraction of the adjacent tissue, such as fat and muscle. There should be possibility for multiportal surgery for pseudo-depth perception, minimal bone removal, because this takes time and may require reconstruction, and require minimal ICU stay and allow a rapid recovery. Well, why endoscopic orbital surgery? Well, you saw in the last beautiful presentation, the anatomy was presented endoscopically. And the reason is you can see so well. If you do an open approach, as you see on top here, the lighting is right in front of your eyes, and any magnification is loops that you may be wearing. And you have to retract the orbit, the globe quite a bit to see lesions, and you get shadowing. But with an endoscopic approach, you have a high amount of magnification as possible. You have a narrow cylindrical pathway. The light is at the end of the endoscope, and so you don't have as much shadowing, and you don't have to retract the globe nearly as much, and that's very important. So endoscopic orbital surgery allows smaller incisions, less globe retraction, improved lighting, better magnification, improved fat and muscle retraction. And this is key here. It allows 2 surgeons or more to work synchronously, and it allows the entire team to watch the operation on the monitors. And all of these factors add up into improved precision, less morbidity, and better outcomes. Now look at these images of the medial orbital wall and the orbital apex. This is a beautiful optical cavity here without any fat herniation before you open the periorbita. So this gives us very good control of the optical cavity. It's coplanar viewing, as I'll discuss momentarily, and it allows more effective reconstruction working from inside the orbit. Here's an example of doing an orbital apex and optic nerve decompression. You can see the optical cavity. You can see when performing endoscopy through the orbit and through the posterior ethmoid sinuses. So you can see that the apex ethmoid artery, you can see the carotid artery very nicely. So this gives you superb viewing. Well, the elements of an endoscopic procedure are fairly similar regardless of the site that you're doing. You need a portal. You need a pathway or a corridor if it's a preformed pathway, such as a nasal cavity, and then an optical cavity. And if we're doing pituitary surgery, we have a preformed optical cavity from the sphenoid sinus. Obviously, you need a surgical target, and you also need effective retraction and instrumentation. Well, the transorbital, the transnasal approach is the most common endoscopic skull-based procedure we do. And this uses a pre-existing corridor and a self-retained optical cavity as long as it's within the nose. Now, when you leave the nose, you no longer have a retained optical cavity. The technique, the instruments, hemostasis, and reconstruction are excellent, and we export these to the techniques that we do transorbitally. And this shows the primary area that we access with the transnasal approaches, but it's not perfect. When you're operating in pituitary, you need to have at least 15 degrees of separation to prevent instrument contact, as you can see here, and we call this the narrow funnel effect. This issue of instrument conflict can be significant. So you can see if we're operating through the nose, it's hard to get that 18 degree of separation. But if we add other portals, all of a sudden we can open that up and get much greater separation between our hands and instrument. The other challenge is that of biplanar surgery. So if you're operating through the nose, you have to transition into a different plane to operate within the orbit. And what we ideally do is operate in a coplanar approach, so you don't have to transition, as you can see here in this biplanar approach. This is an example of a publication showing periorbital suspension for endoscopic access to the frontal sinus. And here the surgeons are trying to access this through the orbit. And you can see what it looks like here. It's very difficult to tell what's going on, and your optical cavity is very tiny. Now compare that with a transorbital approach to the frontal sinus. This is coplanar, short, direct, minimally disruptive. It's easy, and 1 to 3 surgeons can work through this. The other issue with biportal surgery is we can see our instruments better. If we do a monoportal approach through the nose, you can't see the tip of the instrument. And in fact, you don't know what instrument I'm using here. And so that's through the transnasal endoscopic approach here. But if we do a superior transorbital approach, all of a sudden, you can see the tip of the instrument and you get a pseudo depth perception because you know where you're working exactly. And that's biportal surgery. Whether using monoportal or multiportal technique, as you can see here in these different vectors, you have to plan very carefully to decide what's going to be optimal for you. And these are just some of the endoscopic approaches that I use here. These are all scarless techniques that I use on a regular basis. Well, the orbits, as you've seen, are centrally located, and there are many potential corridors and pathways, both within the orbit and through the orbit. And one of the beautiful things that enables us to do this surgery is the majority of the fat is what an ophthalmologist at Pittsburgh, Tanya Stefko, refers to as squishy structures, so they can be displaced. But you can see there's a large potential space here on both sides, above and below the orbit. Well, with this comes unique safety concerns, namely protecting the cornea. Well, if you use a corneal shield, you can't see the pupil unless it's a clear shield. You want to be able to see the pupil. A temporary tarsorrhaphy suture, where you suture the eyelids together, is definitely helpful if we're using transcutaneous portals, and place it at the medial or lateral limbus so you can see the pupil to monitor what's happening. Hydration is very important, using an ophthalmic lubricant. and having ongoing, what I call communication with the pupil. In other words, watching what's happening to it is very important. It's very important to be very gentle when you retract the orbital contents. It should be minimal traction, gentle, blunt, low pressure, dynamic, meaning you're moving a retractor and you watch the pupil. So never tilt the retractor in behind the globe. You want to have a paraxial retraction following the lateral orbit. Well, the average volume of the orbit is 30 cc's, and yet the average pathway volume is only 3 cc's, so we're only using 10% of this. And this shows a surgical mapping study we did that demonstrated the volume of these pathways. Well, certainly critical in these procedures is neurovascular safety. You have the same concerns that you have with other endoscopic approaches to the brain, but you have more pathways to choose from. So it's really essential to plan the safest pathway with no tight neurovascular structure crossings. There are times when you will cross neurovascular structures, but not in a threatening fashion. Well, there are 4 transorbital pathways. As you can see here, these are the main ones. 1 or more pathways to each quadrant, as you can see here, and these were reviewed very nicely. But when I discuss this, I like to think about this as a global selection. It's not a 360-degree selection of approaches, as many people say, but you have to think globally around all angles of the orbit. And contrary to what we're going to be learning in the next skull base meetings, that the skull base, where they say the skull base is flat, the skull base is definitely not flat. And that's one of the things that allows us to use transorbital approaches to get to the brain in a minimally disruptive approach. Well, the portals were very nicely discussed in terms of how you access this. And I'm just going to go through it briefly. To the superior portal, we simply use a preceptal approach. Now, it's true that we want to try to save the neurovascular pedicles here, but if you have to transect a supraorbital nerve, it's not a big deal, because in 2 or 3 months that sensation is going to return. The medial approach, as we talked about, is a precurruncular or transcurruncular approach. It's very direct. Inferior, you just pull, sorry about that, you pull the lid forward and incise directly onto the orbital rim. And in the lateral approach, you can just dissect directly onto the lateral orbit by pulling the lids laterally. The key area that we need to be thinking about is the superior orbital fissure and its contents, as well as the optic nerves. In general, in most cases, there are actually 3 ethmoid vessels rather than 2. We did a study on that. And one of the nice things about this is the interventional radiologist will not embolize the ethmoids, but you can come in here at the beginning of the case and cauterize them so you can control hemostasis. Let's look at the superior quadrant approach. Here we use an upper lid crease approach, and this shows how very shallow the approach is. And it takes, I don't know, between 5 to 10 minutes to get here. And this is the area of the orbit we can access, or we can remove this bone as needed. And it does get us to the anterior clinoid here, the optic strut, optic nerve, like that. You can tailor the portal to the pathway you need. It can be quite small. And this schematic shows the areas you can access within the orbit and through the orbit and the anterior cranial fossa and between the orbits as well. More schematic showing this. You can also access the frontal sinus for pathology. There you can access the contralateral frontal sinus, contralateral orbit, and the brain. This is when we were operating on a meningioma of the left orbit and anterior clinoid that also involved the temporal lobe. And here you see the internal carotid artery, the optic tract back here. See, we're looking more posteriorly, and here's the olfactory nerve above. So it really gets you very nice exposure. Well, let's look at the medial quadrant here. Here's a precurruncular approach, and you follow the posterior limb of the medial canthal tendon to the bone of the lamina propria, as you can see here. And this allows us to get above or below the skull base. Here I've opened the orbit so you can see the level of the skull base. And so you can actually operate intracranially, extradurally from this approach, or intradurally. This shows some of the areas that you can approach the interorbital skull base very nicely. This is what it looks like, minimally disruptive. And here we're removing the optic nerve for melanoma within the nerve and sparing the globe. And you can see the optical cavity and the retraction that you can get through that. And if we look inferiorly, We simply pull the lid inferiorly like this. This is the area that we can get to as was described very nicely before. And this shows the optical cavity that you'll have. Here's an orbital fracture. Here's a chondrosarcoma, but you get a very large viewing capacity through this. The lateral approach you can see here, we can either do canthotomy and canthelysis, splitting the lid here, or we can incise directly onto the periorbita. We can access infratemporal fossa, the greater wing of the sphenoid here. And if we look down here, we can see foramen rotundum. And a nice landmark is that foramen rotundum and the optic nerve form a vertical line here that will help you orient yourself. And this is what that approach looks like. This is the approach when you're going into the cavernous sinus or similar areas. These are the areas you can get within the orbit. And this shows accessing an encephalocele in the greater wing of this, in the lateral recesses of the sphenoid sinus. Very nice exposure. And by combining these transnasal and transorbital approaches, these are the areas of the skull base that we can now access. Well, what about planning these procedures? Here's a 63-year-old male that came into my clinic after declining a craniotomy that was recommended for a severe CSF leak through his nose. And here you can see the defect in the middle cranial fossa where the CSF leak is in the sphenoid sinus. And planning this, the correct answer shouldn't depend on your specialty. Now, to give the neurosurgeons a hard time showing craniotomies here, okay, this is biased, but this isn't minimally disruptive surgery. If we look at a transnasal approach through this vector here, you can see we have to go through multiple layers of bone, and it's a 75-millimeter approach, and you have to remove this floor of the sphenoid sinus. So that's a lot of dissecting. If we do a transmaxillary vector down here, it's only 60 millimeters long. We still have to go through multiple bone layers, as you can see here. This approach is less likely than a transnasal to damage the Vidian and V2 nerves, but the sphenoid floor is also removed. If we look at the lateral transnasal approach, however, the lateral transorbital approach, as you can see here, it's a 30-millimeter approach. You only have to go through one bone layer. The Vidian nerve and V2 are spared, and the sphenoid floor is spared, and this is what supports the reconstruction. So if we're looking here endoscopically on the left side, you can see we've opened the greater wing of the sphenoid bone very thin. We've gotten into the CSF leak. Mucosa of the sphenoid sinus is still intact. Then we open it up, and here we're looking across the sphenoid sinus, as you can see here. Here's the floor of the sphenoid sinus, and here's our encephalocele. We bipolar that, reduce it, fill it with fat, and we just close the lateral canthus, and the operation is done. Here's pre and post-op. And this is what he looked like a week after surgery. He said he never had pain after surgery, took no pain meds. And this was done 11 years ago, and he never had a recurrence. And I've done others similar to this. 7-year-old anterior and posterior frontal sinus fractures with a large CSF leak. Again, you can go right through this upper eyelid. You remove the mucosa from the frontal sinus. And here's what he looked like 2 years ago, never had diplopia, CSF leak repaired. Here's a patient with an orbital abscess. And when you get imaging, you see that the patient actually had an osteoblastoma. And we did a quadriporal resection going through the nose, both sides, through the orbit, both sides. And you can see her pathology resolved, and she did nicely. An orbital, frontal, and epidural abscess, as you can see here, go through the orbital roof, drain the purulence in the frontal sinus, do a small craniotomy, irrigate, and your operation is done. 94-year-old male with a brain abscess was told he was not a surgical candidate. I was asked if we could do this endoscopically. Same approach. You can see going through the orbital roof, through the frontal sinus into the brain, and drained it, and he did very nicely. But a key point is that transorbital approaches are highly effective for retraction of fat and muscle, meaning that you can create an excellent optical cavity. Here's an aneurysmal bone cyst, and here's pre-op and post-op, and you can see the extent of the bone, both on the anterior cranial fossa and orbit that we've removed, and again, preoperative and post-op. And here we've done the reconstruction through the orbit, and it mimics very nicely the patient's premorbid anatomy. And in fact, after this resection, she had diplopia only in far lateral gaze. Now here we're doing transorbital resection and a biportal approach. This is what the dissection looks like through the nose. So we're instrumenting through the eye, working through visualizing through the nose so you can see the tip of your instrument working. And now we're doing transorbital viewing and instrumenting through the orbit. You see the retraction of the orbital contents. And here we're decompressing the optic nerve. And here you can see with this viewpoint, you can see above the optic nerve and below very nicely, and you can retract the frontal lobe as well. And again, transnasal perspective, transorbital perspective, both are valid, both are good, but they have different applications. Recurrent adenoid cystic carcinoma, she was already blind in the left side, and we needed to decompress the contralateral optic nerve. So here we're looking at an ipsilateral transorbital approach, frontal lobe dura, removing the tumor from the orbit on this side. And after we remove that, look at the extent of the decompression, frontal lobe dura, optic nerve, orbital apex. And this is the contraportal approach operating through the opposite side that gives you that view. And again, this shows you the extent of that view that you can see. I showed this image before of the optical cavity you can attain, seeing all of the optic nerve. Optic nerve decompression, here you're seeing the optic canal. And as we look here, there's a fracture through the optic canal, and there's a fracture in the internal carotid artery as well. So this is a very challenging dissection. And you can see we just lift this bone very gently off of that. And here we're lifting the optic canal out. Here's exposed dura underneath, and then we just repair the dura. Here's a dural repair matrix on top of it. Metastatic esthesioneuroblastoma, greater wing of the sphenoid, we're going to come straight through. Orbital contents, temporalis muscle, temporal lobe dura, frontal lobe dura, foramen rotundum, wide exposure, no diplopia postoperatively. And she did very nicely. And this is what it looked like afterwards. As I finish up here, 78-year-old male with meningioma, referred after 5 prior cranies. You can see the meningioma around the anterior clinoid and the temporal lobe. And again, we do a superior lid incision. Here's the dissection. Here's tumor in the orbital apex and working posteriorly. And then we can see the optic nerve, optic tract, internal carotid artery, ACA, MCA, and the olfactory nerve. So very good exposure. So how do you learn this? The learning curve is pretty steep. And this comes from an article we wrote with Alberto de Soma called Endoscopic Transorbital Levels of Difficulty. So you start out with bone lesions, and then you work with CSF leaks, trauma, and then you work into lesions within the bone, sphenoorbital meningioma, and then work into intraconal lesions after that. Then you can go into what we call stage 3, where you're going into temporal parenchyma lesions, trigeminal schwannoma, where you're taking down the meningoorbital band, and in stage 4, you're anterior clinoid meningioma, internal carotid artery. Working further in stage 4, we're dealing with lesions in the mesial temporal lobe, cavernous sinus, in those areas, and then working in stage 5, MCA aneurysms, petroclival lesions. And so you need to work through these slowly and start out in a cadaver lab, as you can see here. This is Dr. de Soma and his group taking down the tentorial incisura and working on the brainstem, as you can see back here. It's also helpful to attend a course. The 4th International Hands-On Workshop will be in South Korea in November. You can ask me about this. NASBIS workshops, and we're writing a book on this transorbital endoscopic and brain surgery. So to conclude, this is my email if anybody want more information. Quid pretium, at what cost? There are many endoscopic approaches to and through the orbit. Plan the approaches carefully and use vector analysis. It's essential to have effective and safe retraction of the orbital contents, and multiportal approaches will improve the viewing and provide pseudo-depth perception, and also allow you to work on multiple sides of an orbital lesion. This is an exciting field with new applications and major innovations that are on the way. Thank you so much.
Chris, that was masterful. Thank you so much. Really great. And of course, we're saving the questions till after George speaks, but I can already see questions coming up in the Q&A chat box. George, go ahead and tell us how to dance around the orbit.
Can you see my screen?
Yes, but yeah, go ahead, but hit the presentation mode. Did we lose you, George?
Seems like he's frozen.
Frozen. George, if you can hear us, you're frozen.
I think he's still here.
Let me send him a message.
Oh, you think he's okay? Did we lose him, Iggy? I don't see him now.
He's here, but something happened. He is on the list here. Wait,
No, I don't see him.
No, he's gone.
He must
I
have
think he has
lost.
the internet issue.
Yeah, the internet, I think. I'm sure he's reconnecting. Well, let me see if there are. Okay, Chris, if you're still here, let me run a couple of questions from the audience. Nima Amini asks, saying the sphenoid floor plays a key role for that reconstruction, perfect entry through the lateral. I guess he's asking how common is the CSF leak from the case you described with CSF leak. How common is that? We certainly
It's a great question. Overall, it's a rare source, but it's a particularly challenging source because many cases who have a craniotomy will end up with numbness in V2 and a dry eye from the Vidian nerve. Working on a paper with Ted Schwartz about that. So it used to be thought that this was a leak in Sternberg's canal. I think that that thinking has maybe gone out of favor. But in any case, it's unusual. But when you do see it, it's a challenging area to get to. But I found that you can get to it quite simply without much morbidity. And having the sphenoid floor intact is very nice because it'll support your fat graft. And you can put a little added packing that dissolves, and it prevents the patient from blowing air into the area and like that. So it's highly effective.
And while I'm asking you questions, while George is reconnecting, Dr. Keaton Piper is saying, is there a measurable limit on how much you can retract the orbit?
So all of our pathways, we retract the globe less than 1 centimeter. And we know that we have never had a case of blindness from that. And I have never pushed the globe until we have had blindness. So we don't have an answer to that, except that it's been demonstrated to be highly effective and safe. And that there are multiple meta-analyses going over the complications, and blindness is extremely rare.
Okay, thank you. George, are you back? Maybe you lost some bandwidth there or Wi-Fi?
Yeah, my computer crashed. Logged in from let me see if I can. I'm logging in right now again from the hard line.
Okay, no worries.
It should be like 1 minute.
Yeah.
Otherwise, the Wi-Fi I don't think it's gonna make it. But
okay,
something happened with that.
Chris, I'll ask you. I'll keep asking you questions. Talk to us about how important is it to reconstruct the roof of the orbit, whether you use a transorbital or whether you use a craniotomy. I mean, in the old days, I thought it was essential to reconstruct the orbital roof to avoid pulsatile exophthalmos or inophthalmos, but Bill Caldwell and I and others have discovered you actually don't need to, but love to hear your perspective.
I agree 100%. And when it is reconstructed with external table or other bone grafts, it tends to be very non-anatomic. So I've left the vast majority of the orbital roof unreconstructed. And yes, for 1 to 2 weeks, the patients may have pulsatile exophthalmos, but then it uniformly resolves. I have never had a case where it persists. Have you had a recent one where it does?
No, my longest one, though, is about 5 months, actually. I remember him very well, a very lovely rabbi, wonderful rabbi. It went away. It went away, but it took a long time. This is definitely my longest. Yep. And but we really removed the entire roof. Okay, George, looks like you're back online. If you go on, yeah, we got you now. You're muted. When you can unmute yourself.
And you can hear me now?
We can hear you.
Okay, perfect. Well, it's hard to follow these two fantastic talks. I've learned so much both from Chris and Maria, and not only today, but over the years as well. And I think, thank you, Jacques, for inviting me for this fantastic series. So the prior couple of talks, I think, had a little bit more of an emphasis on the orbit itself. We're going to move a little further back. And then today, we're just going to discuss a little bit how to dance around the optic nerve. And this title, I like this analogy of dancing around the optic nerve. We're just more or less almost dancing around a fire. And the reason for that is because the optic nerve and the optic chiasm, perhaps more than any other nerve that we deal with, has the less capacity to take any pushing around, and particularly the microvasculature around the optic nerve is just so unforgiving. So it's so important to be very, very careful around it and devise strategies to minimize retraction of the nerve and disruption of its vasculature. If we get too brave, it's not unusual for us to get burned. Now, I'm not sure there's any debate that's more of a hot topic in skull-based conferences and discussions when it comes to choosing like the approach for lesions that are surrounding the optic nerve, particularly when it comes to choosing like a ventral or lateral approach, and endonasal or more lateral approach. And I've been lucky to have trained with many of the pioneers of both the lateral and ventral approaches, and also the radiosurgery. So and over time, you kind of put everything together and develop your own preferences. So today, it's kind of my take on how do I go around and try and choose an approach when it comes to lesions around the optic nerve.
Hey, Joel, sorry to interrupt you. Your videos look a little choppy. I'm sure you're going to show some videos later. Are they like these, like the kid who was using the gloves? It was not smooth. Is this how it was supposed to be? You know what I'm saying? We can wait and see.
Yeah, I can always pull it on the other one. I was hoping that this one would have a little bit more bandwidth, but
yeah, it may not be, but we'll see. We'll see. I can let you know. Let's keep going.
Okay. Well, so one of the rules that I try to follow is that I try to avoid crossing neurovascular structures, and also respect the arachnoid and microvasculature. And in order to do that, I think one of the most important rules that is not my rule, but following a lot of the rules of the skull-based surgery is follow a tumor from where it came from. If you follow a tumor from where it came from, you're more likely to stay within that anion skin and try and preserve the arachnoid and the microvasculature. The optic nerve doesn't take a lot of manipulation, particularly when it's not already stretched. And then working together with a lot of our partners, either oculoplastics or ENT, try and find the optimal approach usually is key. There's also important anesthesia considerations to putting a pre-induction A line and keeping the maps up, steroids. And one of the things that I've come to do over the years is to try to avoid fluid swings. So try and avoid too much mannitol. If you think you're going to retract and you're not going to get to a cistern early, try and give and put a lumbar drain, for example, and drain fluid like that, as opposed to give them 100 of mannitol, then they get dehydrated, and then there's a catch up after that. And of course, as Dr. Morkos always teaches us, remember to break all the rules if needed. So the ventral versus lateral skull base, if we can imagine the brainstem, all the cranial nerves, it's very easy to sort of separate what comes lateral to the cranial nerves versus medial to the cranial nerves. And that's just a good rule of thumb of not crossing any neurovascular structures. And of course, the ventral surgical corridor can be very versatile in the sagittal plane. But also, as Dr. Al-Mefti teaches us to try and use the arachnoid as your friend, if we follow the epicenter of the tumor, if we think of a fist going into a balloon with the outer arachnoid being the outer layer, and the tumor being the fist, then all the vessels or nerves are sort of in between them. So trying to follow the tumor from when it came from is usually a good strategy to try and stay on the good side of all those small vessels. So this is a very straightforward tuberculosella meningioma. And usually does this show a little bit better, or is it choppy as well?
No, it's choppy. I mean, we can see it, but it's missing some frames. It is choppy. Yes.
Okay.
Well, you have a better Wi-Fi kind of server, or is it going to be complicated? I mean, the image is very clear, just choppy.
Okay. I can try and pull it on my, if it's horrible, I can try and pull it on my laptop, but in the interest of time, why don't we keep going for now?
Okay. All right.
Oh, I'm not going to belabor this, but this is a pretty straightforward meningioma. The arachnoidal layers are very well preserved here. And this is what you first do and kind of feel good about yourself with preservation of all the arachnoidal layers around that suprasellar cistern. But obviously, that's not always the case. There's another example of a patient that has like profound invasion in the optic canal. This is almost encasing the optic nerves here, and that's not unusual for tumors and the tuberculum cella meningiomas in particular, or the diaphragmatic ones, to be invading the inferior medial optic canal. And slight extension over the canal is not an absolute limitation. We'll talk a little bit about how lateral you can go. But it does it does require good exposure of the optic canals, almost like a 270-degree approach. And usually the hyperostosis that happens with these tumors does give us a little bit further leeway into the supraoptic space. Now, this is a tumor that, as opposed to the prior one that we saw, is highly invasive. It's invading the arachnoid, and having this view, I believe it's superior in order to really understand how it's enveloping all the microvasculature, the branches of the supraepiphyseal artery going both to the stalk as well as the optic nerve. And again, following them where they came from allows you to sort of chase them without necessarily crossing them. And then going into that inferior medial optic canal and chasing the tumor there. Of course, retrochiasmatic tumors, that's a natural corridor to follow these tumors. I'm not going to belabor this, but following under the optic nerve, there's a more rare case of a hypothalamic astrocytoma that we thought originally was a craniopharyngioma. And you have beautiful view into the third ventricle and the interpeduncular cistern. So what are really the limitations? Is it extension lateral to the carotid? I don't believe that in most cases, extension lateral to the carotid is a limitation, because as you're expanding your view coming transnasally, This part, again, is in the correct side of the arachnoid, and you can peel this part of the tumor in. How about extension to the roof of the orbit? And again, there's multiple papers showing that up to the mid-orbit is a fair game, and by, as Dr. Mo said, retract the squishy structures, like Tonya says, we can get further access into the lateral orbit up to its midpoint, more or less. What is a limitation, however, is extension into the clinoids. And a tumor like this that is completely surrounding the anterior clinoid processes, that's a tumor that if we go transnasally, we're going to leave residual tumor. And that's an area that is a limitation. For example, if we have significant hyperostosis, like such as in this tumor here, where we have significant hyperostosis over the clinoids, this actually expands our corridor. We can get a little bit further past the mid-optic canals, which is usually what we consider as a limitation. And as you can see here, here's the optic nerve, and then see how much this hyperostosis allow us to get superior to the optic nerve and get almost more than a 270-degree decompression into that anterior clinoid. And that can expand a little bit our exposure, but still, as the tumor comes lateral to a clinoid or further, more anterior into a clinoid, this approach is further compromised. So, such as this tumor that we saw earlier, then an all-point approach, perhaps an approach where we do like a transbasal approach. It's an approach that may be ideal here. Or obviously, if we choose some other approach, we're probably going to leave some residual, which is also okay. But this is the approach that I chose for this patient, for example. Now, which of the suprasellar meningiomas are amenable to open approaches more than others? And which are the ones that we think of in terms of choosing the ventral corridor more than a lateral corridor, even though you're going to leave a residual? So both an olfactory groove meningioma and the plantar meningiomas, they come from more anterior than the microvasculature of the optic nerve. So the effect of them is that they splay, as we know, the optic nerves apart, and they displace the microvasculature posteriorly. So when we come from an open approach, usually we can still follow the tumor from where it came from. Now, tuberculum cellar meningiomas tend to push some of the optic nerves superiorly more than posteriorly. And that's even more accentuated in diaphragmatic meningiomas, such as this one here. So diaphragmatic meningiomas, in these tumors, usually the optic chiasm is actually prefixed as opposed to postfixed. So when you come from a lateral approach, essentially the tumor is completely on the other side of you, and then the supraepiphyseal vessels are in between you and the tumor. These are an example of a diaphragmatic meningioma. Again, you see that there's some lateral extension past the carotid, but that's usually not that much of an issue. There's also somewhat of a flat skull base, which is also more usual with these tumors as opposed to the tuberculum cellar meningiomas, that they usually have the hyperostosis, sometimes can provide like a favorable angle of attack. But this tumor is going all the way posteriorly behind the optic nerve. So when we come from lateral, it's going on the complete wrong side of what you would do. Again, the supraepiphyseal vessels are in between you and the tumor, and then they're diving posteriorly, even in the posterior fossa and the interpeduncular system, like we showed earlier. I'm not going to belabor this, but also the stalk can even be enveloped in these tumors. They're generally kind of a different animal than the rest of the quote-unquote suprasellar meningiomas. So these are tumors that I would rather leave some residual, or if there is an extension in the anteroclinoid, let's say, as opposed to try and tackle them with an open approach. Now, when tumors start from laterally, such as, for example, clinoidal meningiomas, etc., then obviously the approach is lateral. And even if you have a residual of a clinoidal meningioma that's extended into suprasellar space, attacking it from a medial or a ventral corridor, I believe, is a mistake, because then all the microvasculature is going to be in between you and the tumor. And that's a mistake that has been done before. Of course, we have like the standard open approaches. This is a COZ approach for this tumor, and anteroclinoidectomy, falling down and identifying the carotid, finding the carotid, and sort of excavating from the inside out. I don't know how much how well it's playing, but again, sort of working from the inside out again, starting from the anteroclinoid and then connecting laterally to medially. But the transorbital approaches, and we've heard already two beautiful talks about this, are another very viable way to get there. And there are a lot of variations. Some of them are transorbital. Some of them are through incisions around the eye. We do this surgeries with our oculoplastic surgeons. And some of our go-to procedures are the eyebrow, which gives you beautiful exposure to the anterocranial fossa. You can remove the rim, for example, to get a little bit more superior exposure for an ACOM. If you extend it a little bit inferiorly and extend below the orbitozygomatic suture, you can get a good exposure in the middle cranial fossa as well. The lateral canthus with the lateral orbitotomy is more of a middle cranial fossa exposure. It's beautiful exposure for either sphenoorbitomeeningiomas or trigeminal schwannomas, etc. And when you combine them, when we saw a beautiful example by Dr. Mo, when you combine it with an eyelid incision, you can really do like a mini OZ exposure and have a beautiful exposure in both the anterior and middle cranial fossa. Trans-eyelid incision, transfrontal for a more medial exposure in the anterocranial base. Now, large frontal sinuses and large supraorbital ethmoids are things that I always try to take in consideration. And then it is a little bit harder to repair these lesions when you do a transorbital approach. You can, of course, use fat, and we do raise a pericranial flap. There's a mini pericranial flap, but when you have a large defect, that can definitely be a contraindication, at least for me. I can't take credit for any of these cosmetic results, but again, working in a multidisciplinary manner, and with Dr. Stefko as well as the others, you can get very good cosmetic results after transorbital exposures that avoids a lot of the disruption that comes with a pure lateral approach through the muscle. This can be used for both intraaxial lesions using a more inferior to superior exposure. This is an example of an ependymoma, actually, in the anterior right frontal lobe. Intraaxial tumors, such as an epidermoid with a lateral canthus or sphenoorbital meningiomas, such as this one, the lateral canthus exposure using the opening of the eye as well can provide like a very good exposure. And this eyelid incision as well as the lateral canthus can be used for even larger tumors, such as this one here. And it really provides like an exposure, almost like a COZ approach. Now, this is not an approach that I would, at least at this point, tackle endoscopically. I do like the approach that it gives, with an open approach and using all the same tools that we use with traditional skull-based surgery. So, again, working with our oculoplastic surgeons, mapping the frontalis nerve for our lateral extent of our exposure, and the zygomatic branches, and raising the flap. The osteotomies are essentially the same manner that we would do them for one-piece COZ. And reducing, doing all the bone work, and then starting again in this normal fashion, both from medial to lateral and from lateral to medial, identifying only the vasculature that's pretty significant involvement of the MCA branches here. And then peeling the lateral wall of the cavernous sinus and all the way up to the anterior petroclinoidal ligament, and then the reconstruction. Try to do as good of a watertight closure as possible, along with fat. That's a go-to reconstruction. And again, these are some of the cosmetic results that you can get, and it is actually pretty hard to see that. Of course, avoiding that altogether with an atraumatic transorbital approach, that's all better. But I think that at least I am not as comfortable in doing that. Some of the larger tumors. This is an example of a transorbital median for an encephalocele. Again, working with both our ENT surgeons as well as our oculoplastic surgeons to reduce it and put a mucosal graft, and that healed very nicely. For vascular lesions, Dr. Maria Periselda showed the variations of the ophthalmic artery. Both the transnasal route as well as the lateral route are a good approach. Usually, obviously, these are lesions that are approached with a pipeline, etc., but there are obviously contraindications in many patients, either because their inability to take anticoagulation and antiplatelet medication, and both the endonasal and the lateral routes are viable alternatives depending on how medial the aneurysm is and how anterior it is, etc. There's actually a case that we did recently of this cavernous sinus aneurysm presented with an ictus, an almost complete cavernous sinus syndrome, and they were unable to pass a pipeline through it. I was concerned about doing a balloon test occlusion, given how much thrombus there was already in the aneurysm, and the fact that they couldn't go through. So we decided to essentially bypass it and trap it, and try also to decompress it by trapping it. But this would require actually getting access to the carotid artery proximal to the ophthalmic artery to keep the ophthalmic artery open. Of course, you can try and the majority of the times you can get away with taking the ophthalmic artery inconsequentially. But if you can save it, obviously that's always beneficial. I'm going to go through this in too much detail, but we did radiograph, and this is nicely flowing. So occluded at the neck, but then trying to get access proximal to the distal dural ring here, and sort of just dancing around the optic nerve to try and get access to the clinoidal segment of the carotid artery. It does require a little bit further dissection deep into the dural rings and dissection of the ophthalmic artery here. But eventually create enough of a dissection to be able to place a clip that was proximal to the ophthalmic. So this ophthalmic will fill retrograde from the bypass, and the patient did not have an ECOM, had a very small PCOM, and then tied it at the neck, and then tied the ophthalmic. Also perform a suction decompression here to decompress the cavernous sinus, and occlude the aneurysm, but also thankfully tried to preserve the ophthalmic artery filling here as well. Time. Working across the optic nerves is a case also relatively recently, but creating a corridor by complete dissection of the cistern above the optics of the lamina terminalis can give a nice corridor across to the contralateral cilium fissure. Is a case of bilateral MCA aneurysm with a very short contralateral M1 segment. Here I had to do something that I never had to do before, which is sort of a contralateral anteroclinoidectomy. that was necessary to. You see the aneurysm. This is the left anterior. Will come from the right side approach, but it's hidden under the contralateral anteroclinoid. Perhaps not as good of a planning and movement on my part, but perform a contralateral anteroclinodectomy here and get a little bit better access to the aneurysm. This was medially pointing, so provide a little bit better access. So it did require adjustment of the construct to try and get the whole aneurysm, and then finally tackling the ipsilateral aneurysm. And this is the final result. I'm going to go a little bit quickly. Sometimes more than one corridor is better. This was a case of a central skull base calcified meningioma. This is the one that even though much of the pathology was ventral, that I chose to go lateral first to decompress the nerve through a pretty comprehensive anteroclinodectomy and create kind of a corridor and a landmark to find in a bloody field that would decrease the blood loss before actually decompressing the nerve and then going intranasally to decompress the nerve. Here we're removing the optic struct from the other side, so a 360 decompression, dancing again around the optic nerve and removing all the involved dura. Here's the ophthalmic artery coming into view, so trimming the distal dura ring up to the ophthalmic and the diaphragma sellae. So this is essentially a diaphragmatic meningioma that's secondarily calcified. You want to think about it like that. This is the final result. Still no Simpson grade 1 intersection, but it's as good as we could do, and we're able to improve her vision. So in conclusion, the ventral and lateral approaches in trying to dance around the optic nerve are essential parts of the toolbox. And one of the takeaway points, if nothing else, is that the epicenter of the tumor probably is the single most important thing in dictating the best approach. And when choosing a lateral approach, we have many transorbital approaches that can be a powerful, minimally invasive alternative to traditional lateral skull-based approaches. But we always have to be careful, as Dr. Mo has also shown, that these approaches are not compromising what we can achieve our instrumentation and our visibility. So I think we're not too far over time.
Thanks, George. Thank you very much. I mean, you're a perfect example of why skull-based surgeons should be tailors and not married to one specific technique and know how to juggle the different techniques. I think the audience, got that message very clearly from your beautiful, even though they were choppy, the beautiful videos. Let's see, George, let's ask you. Nima Amini wants to ask you: is it wise to drill out the optic canal for cases like anterior clinoidal meningiomas? I'm not sure if you mean endonasally, or I'm not sure what he means, but is it? Go ahead.
Anteroclinodal meningiomas are, again, tumors that are starting laterally to the optic nerve. So I think tackling them endonasally, perhaps there's a role for them if you're just trying to create like a quote unquote less invasive option without creating a leak, etc. I don't think you can get too much out of it. But doing just a bone only decompression endonasally, I don't think there's too much role, but tackling them certainly endonasally is the absolute wrong corridor. When I try to do anteroclinodal meningiomas laterally, Yes, I try to drill the optic canal first and then go intranasally. And then go open the dura and resect the tumor. I know that's debatable. Bill Caldwell always is wary about, all the manipulation that you do, like when you do an antroclinidectomy first and then decompress the tumor. But I think it's worthwhile, and obviously not every case is the same. I don't know if I'm answering the question.
I think you are. Carolina, Dr. Benjamin, my partner, I don't know if she has any comments or questions to the panelist, or you want anything, Carolina? You're muted. You're muted.
I was going to actually ask Chris the same thing about the reconstruction. I saw that you had one reconstruction of the inferior, right, of the inferior orbit. Is that something you do routinely?
Of the inferior orbit, it just depends on how much bone is gone and how much of the periorbita is removed. If it's a significant amount, I certainly do. For smaller defects, I start with PDS sheet, polydioxanone, which is really an amazing material because it's non-adhesive. If I have larger weight-bearing defects, then I use a titanium sheet. But the other place I'll use a PDS sheet is an orbital roof reconstruction, particularly if the levator or superior oblique are exposed, because the PDS sheet leaves behind a glide layer once it dissolves. And even if you have to go back in and reoperate it, it's a very separable, easy to dissect plane. So yeah, it depends on the size of the defect and the location. It's a great question.
Fantastic talks, both, everybody.
I have a question, Dr. Mo, if there's none else.
Go ahead, George.
Chris, for the sort of incisions within, not externally, but the transcaruncular, etc., and using the endoscope, what would be obviously you showed multiple indications, but in terms of tumors, what's the extent that you would chase a tumor with an approach like that?
Great question. And again, that's something that I'll do vector mapping with at the beginning of the case. If it depends if there's any evidence of extraocular muscle involvement. Once the extraocular muscle involvement occurs, then we're talking about sacrificing the eye and doing an exoneration. For benign tumors, we'll do ones that are quite large. For anterior clinoid meninge and things like that, often do a superior approach. So great question. Really depends on the location of the tumor and the extent, whether it's benign or malignant, pushing versus invading. But whenever you can, starting out with the vector analysis at the beginning is very helpful.
Great. Let me invite now Matthew Sun, our fellow, to present a case to our two panelists.
Okay, let me share my screen.
And Chris, one quick thing: do you use eyelid or eyebrow at this point?
I'm not a fan of eyebrow, and the reason is because an eyelid incision will get you to the same place. You may need to extend it further laterally. But I talked to our residents about coefficients of distension and axis of rotation of a flap. Fancy terms for, can you just make the incision a little bit bigger? I think incisions through or around the eyebrow are not attractive. I admittedly am also a facial plastic surgeon, so that's concerning to me. But there have been studies where one of the most defining features in recognizing somebody is their eyebrows. And it's definitely something we look at. And I think there are a lot of photographs. It's not too hard to photograph an eyebrow and make the incision look favorable, but I've sure seen a lot that don't look great. So super question. And most of those we can get through an upper eyelid crease approach.
Thank you.
Okay, if there are no more questions, I'll go ahead and present this case.
Go ahead.
So this is a 52-year-old male who 8 years ago at an outside hospital was found to have proptosis and underwent subtotal resection of a tumor within the orbit, and the pathology came back as solitary fibrous tumor. And unfortunately, his initial surgery 8 years ago left him blind because of hematoma post-op. And he then now presents to our clinic, an oculoplastics clinic, with 1 month of progressive left eye proptosis and eye pain. So on exam, he has no light perception in his left eye, but extraocular movements are otherwise intact. And I'll show you, this is the only imaging we have before his original surgery 8 years ago. It's a CT scan. And he had a transorbital approach initially 8 years ago. It's unclear how much of the tumor they resected, but when he then came back to us, it's clear that now it's even bigger than the original tumor. And show you the thinner cuts as well as the coronal. Going all the way back to the orbital apex. And the proptosis is obvious even on the MRI scan. Here's the CT. You can see evidence of the transorbital approach they did before. So the question for our speakers today, how would you treat this recurrent tumor now?
Chris, you want to have a first dab at this?
Sure. What's the patient's goal? Is the patient's goal to preserve the non-seeing globe? Does the patient have cosmetic concerns? What does the patient say?
Patient has a lot of pain, so he wants the pain to go away, and also the proptosis. He wants that to be resolved.
So, given that setting, solitary fibrous tumors, obviously, as their term, can be quite fibrous and difficult to remove. If you do a monoportal approach, you're going to be doing a lot of tugging on it. Optic nerve is not an issue. You do want to try to save the extraocular muscles. So one possibility is to detach the extraocular muscles, have your oculoplastic surgeon do that and widen the approach. But I would start out probably by trying to pass it between the extraocular muscles if possible. So I would do a biportal approach. I'd probably have to look at the images a little more closely, but I would do a lateral transorbital approach, and then a medial transorbital precaruncular / transnasal. And the reason is you want to be able to manipulate the tumor from both sides. When we're seeing people doing transnasal resection of orbital tumors, we aren't seeing the deep side of the tumor. We're not seeing the lateral side of the tumor. And so it's always scary to me because you don't know about the vascular supply. So this is the type of thing where I think you want to do a kind of push-pull technique. And a lot of it would also depend on the how fibrous the tumor is. And you may well have to change your plan or add a portal such as a superior portal. But I think you have to be a little flexible based on what you see intraoperatively. I think you can preserve the globe, and I think you can preserve it as a mobile structure for aesthetic reasons.
George, how do you guys do this in Pittsburgh?
Yeah, again, I think I completely agree with like Mo in terms of what the goals of surgery are, and the fact that the patient can't see already, I think there's a huge plus. I think you working, again, I would probably 100% involve Tony Stefko in this or one of our other oculoplastic surgeons. But I think, and again, studying the images a little bit more in detail, but I think the main surgical corridor here is going to be between the superior rectus and the lateral rectus. I think that's where it comes closer to a surface. So do an incision like an eyelid incision, and getting that corridor, but then perhaps extending more medially and creating another corridor medial to the superior rectus, as Dr. Mo said, to try and sort of have a better understanding and visibility of the medial aspect of the tumor as well, and try and tackle it like that. Whether to detach the tumor or not, or whether to detach the extraocular muscles or not, I guess can be dictated, intraoperatively if you're having more trouble seeing.
One other consideration. Oh, sorry, George.
Go ahead. Yes.
No,
One
go
other
ahead.
consideration. It looks like the orbital roof is distended superiorly. So it's actually possible to end up with enophthalmos after removing this. Unlikely, but it is a consideration. And if you're concerned about that, bringing down the orbital roof at the end of the case, or actually removing the orbital roof to let the brain drop down afterwards, let the frontal lobe take up some of that space, may also be useful. And the way you gauge that is by doing Hertel's exophthalmometry. And you can do that on the table at the beginning of the case and at the end. And the patient is going to have 2 millimeters of further enophthalmos at the end after the edema goes down. So in other words, you want to have mild proptosis at the end of this operation so that you end up with symmetry. And if you have symmetric lobes or enophthalmos, it's going to be worse afterwards. So consider using exophthalmometry perioperatively.
Would you ever use fat intraop just to fix that, as opposed to try and reconstruct the roof, I guess?
It's certainly a possibility. And the thing is, though, I'd want to do that outside of the periorbita if I could, to make sure you don't get inflammation to the extraocular muscles.
Okay, Matt.
So I think our panelists, our speakers, really brought up some really good points. Just kind of going over the treatment options. Obviously, surgical resection is the standard of care for solitary fibrous tumors. And, we've already talked about different types of approaches and, multiportal approaches, combining endoscopic and nasal, even with transorbital approaches. And obviously, craniotomy or cranioorbital approach is one option as well. Radiation is not really standard of care, but there's some case reports of these tumors responding to radiation, usually the really malignant ones, and this is probably not one of those. And then targeted therapies, the efficacy is fairly limited. There's some small series using anti-angiogenic therapy for solitary fibrous tumors. And so what we did was, dual surgical team combined with oculoplastics. We performed a cranioorbital approach for this resection. We unfortunately don't have the surgical video, but removed the orbital rim, removed the orbital roof, and got wide exposure, and resect the tumor, and replace the orbital rim and part of the orbital roof back, and then posteriorly and laterally used a small piece of mesh to also reconstruct the orbital roof. That was done by our oculoplastics team. So interestingly, postoperatively, there is actually a pretty significant residual on the MRI. And as you can see here, patient still has a fair amount of proptosis as well. And our oculoplastics team also did fair amount of resection. They also felt that, a complete piece of tumor, which was very fibrous, very tough and adherent, was resected. And it was, as you can see, even on the pre-op MRI, there's some septations on the contrast and T2 sequence imaging. So perhaps there were two separate lobules of this tumor that, one of them was resected. Here's the coronal and sagittal of the residual. And so at this point, I was wondering for the panelists, what would you do at this point?
I think similar type of situation. I think the value of a transorbital endoscopic approach is that you can make a very significant orbital optical cavity, so you can really explore nicely, and you can explore essentially globally. So again, it's you guys did a beautiful job, and it's you don't want to critique other surgeons because it's hard to be in the situation that they were in. But the other thing you might think about is if you were able to find it, what kind of instrumentation you use to remove it. So for example, radio frequency aspirators are sometimes helpful in more fibrous tumors. Sometimes you need to try different instrumentation to remove it. But if the patient's happy, maybe you're good the way it is. George?
Yeah, perhaps nothing. Actually, the way, if you go back on the coronal, I think most of it is actually coming in inferiorly and medially. So considering like perhaps an endonasal corridor also an option here. But again, it all comes down to what the goals are, and the patient is willing to go yet one more surgery or not.
You could potentially even just decompress it, take down the lamina transnasally, and take down the orbital floor transnasal, transmaxillary, and that may provide you some more room.
It is, as Chris, as you said, it's a matter of getting the best visualization intra-op, and whether you use the microscope or the endoscope, and that probably would have prevented this residual from being left there. But Matt, do you want to carry on?
So we actually talked to the patient, and he still felt that he wanted his proptosis to get even better. So after discussion with the patient, we took the patient back to the OR. We ended up opening up the original incision, our first stage incision, and basically did a redo cranial-orbital approach for the resection. And this time, we were fairly aggressive, under the microscope. First really went as posteriorly as possible, try to dissect the lesion, trying to find the border, although it was very stuck, particularly at the orbital apex, to the different muscle tendons. But we were able to get a kind of a near total resection, but there's still a little bit of residual you can see here post-op.
Very nice result. Looks quite a bit better.
Yeah, the key, and the reason we brought this case in, Chris, is, more than me, there are many in the oculoplastic field who actually don't use a microscope or an endoscope for that matter. And it's interesting, many of neurosurgical instrumentation and visualization, a lot of it, we learned it from ophthalmologists, and to see some, what I'm saying? Sometimes interesting, the training, I guess, in oculoplastic doesn't always include microscope. Is that a perception?
Yeah, I agree. And that was one of the points I was trying to make with a slide showing the benefits of orbital endoscopy in terms of where it places the lighting and it changes the shape of the optical cavity. You need less retraction. But the other thing is adding navigation. So one of the ways you might have found more residual tumor at the very beginning in the first case is by doing navigation and seeing that you've actually opened up all the areas where the tumor exists. So I'm a heavy user.
Also, I'm sorry, I didn't want to interrupt, but the ultrasound also is a valuable adjunct for the orbit. I think you have a very good window to be able to see particularly larger lesions.
Absolutely.
Thanks. Eva, we'll go to Eva now. And by the way, somebody in the audience asked whether stereotactic radiation is an option here. It's really not for this type of pathology. Go ahead, Eva.
Okay, so this case is also solitary fibrous tumor. So it's a 59-year-old male who initially presented to another hospital back in 2014 because every time he would blow his nose, he would have periorbital bruising. And this also occurred when he would bend down or exert himself. And so they thought it was some kind of vascular lesion. And so they got an MRI. The MRI is shown here on the right. And this was back in September of 2014. And so then, because they thought it was some kind of vascular lesion, they actually ended up treating him with bleomycin sclerotherapy at this outside hospital. So then after this, he presented again later on with worsening proptosis and diplopia. So now they got another MRI, which shows that this lesion had now increased in size. And so this is in June of 2016, which is about a year and a half later. And so then they did a transconjunctival orbitotomy and did a biopsy at that outside hospital. And they actually stopped the biopsy early because they got a lot of bleeding. And so the pathology was inconclusive. And so now a few months later, he had even worsening symptoms. And so they got an MRI, which is here shown on the right side. And then the old MRI is on the left. And it seems like the lesion's even slightly bigger now. And so now again at the same hospital, they did an orbitotomy via a Lynch incision to try to biopsy the lesion. And now this pathology at that time showed a cellular solitary fibrous tumor with mild to moderate atypia. So then now they sent the patient to us for evaluation, and here's his MRI on the right side. And at that time when he presented to us, he had proptosis, hypoglobus, and wasn't able to adduct his eye. And so we wanted to ask the panelists, how would they manage this patient at this time?
How's the visual acuity?
So they actually, this was back in 2017. It wasn't really documented, but based on the only ophthalmology note that we had was that he didn't have any kind of like compressive optic neuropathy. They didn't have a visual acuity documented for some reason.
George, you want to go first?
Yeah. So what was the incision? It was a Lynch incision that was used.
Yeah.
I think this is still sort of the optimal trajectory. To Dr. Mo's point here, I think potentially trying to expand that. Obviously, that's going to be a bloody tumor. Trying to expand that to have like a multiple trajectories to it, potentially even with like an intranasal corridor as well. So combining the two, I think having sort of non-stick bipolars and a microscope and having potentially the endoscope available from both portals and as well as ultrasound potentially. I think that's going to be key here. But I think, with the progression and the symptoms, I think it's warranting resection.
Yeah, those are great points. This is not behaving like a typical solitary fibrous adenoma. You wonder how accurate that was, and then that also starts to bring in a role for potential post-operative radiation. I don't know, what the status of the optic nerve is. These days we'd get OCT and try to see if there were any early changes. The fact that the patient had some weakness on abduction makes you wonder if the orbital apex is starting to become involved more deeply beyond what you're seeing. I agree completely with George that an anterior approach is a good idea, but also I would start transnasally, and I would want to decompress the lamina. so that you could have a little more room for when you're working on the tumor. I would also try to find the ethmoid arteries, and I would try to coagulate them early on, because that's the only chance of reducing the bleeding that you're going to encounter. A superior eyelid approach would be very nice, because you could start outside of the tumor, above, under the periorbita, and you could sneak medially and see the ethmoid arteries from above and ligate them. You could go back and see the optic nerve and see how the pathology is behaving there. And then again, a multiportal approach is going to be very useful. A Lynch incision in general, I'm not a big fan of, because it puts you medial to the lamina, so the vector is off. I would think about doing a transconjunctival approach, precaruncular, transcaruncular, and moving backwards from there. There's no question you definitely want to work with your with your oculoplastic surgeon, and maybe this is where the chat GPT was correct, that we really need to learn to communicate with them at the beginning of the case, before the case.
Okay, Eva.
So we ended up doing a terional crani with a supraorbital craniotomy, and then superior orbitotomy. So we took off the roof of the orbit. And so oculoplastics, after we got them the exposure, oculoplastics went in, and they were able to get all of the intraorbital lesion. And so now this time the pathology actually came back as a malignant solitary fibrous tumor. And now the Ki-67 was 10%. And there was 7 mitotic figures per high power field. And so, now we followed the patient. And so this is 3 years after his surgery by us. And so in May of 2020, he actually presented again with 1 month of flashing lights in his right eye. And so at this time, his visual acuity was actually 20/30 in the right eye. And then he had baseline diplopia with far right lateral gaze. And so now we want to see, how the panelists would manage the patient now.
Yeah, and anything different from, well, first of all, Chris, you obviously recognize that this was not a typical course. Anything you would say different than you've said before, both of you, for this second recurrence?
I would have radiated the patient. I would have given significant thought to radiating this after the first, probably with the proton beam radiation. Now, having said that, the patient will get cataracts from the radiation, and the patient may preserve the eye, but they often become quite tender, painful, and may end up having exoneration later. So not proceeding with radiation was perfectly reasonable. But I think you guys did a brilliant job with this.
Just for the sake of time, go ahead, Eva.
So now this time we ended up doing an endoscopic transorbital approach for resection with our ENT colleagues as well as oculoplastics team. Here's the post-op MRI from 1 month post-op, and it was gross total resection at that time. And so now actually the pathology was, even worse. It was high-grade hemangioparasitoma, WHO grade 3, Ki-67 was now 30%, and greater than 20 mitosis per high power field. Would you do anything differently that you mentioned?
Now, go ahead.
No, go ahead. I mean, I guess the radiation, obviously.
Right. I was going to say, at this point, I think you should have more ammunition to be aggressive.
Yeah.
But the question then also becomes, you're going to radiate this eye. As I mentioned, there's a very high chance a patient's going to have a painful, not useful eye. And so I would have a serious discussion with the team about exoneration at this point, both because there's a good chance that what's going to happen in the future, and also because you may improve the efficacy of radiation. This patient has a life-threatening tumor at this point, and so you need to change your tactics just a little bit in your thinking, I think.
Yes, but we ended up radiating this patient, and so this is the MRI 1.5 years post-op and 3 months after the photon beam. And so then, at 1.5 years after radiation and 2 years post-op, now this MRI in June of 2022 shows that he has recurrence again in the right orbit, and it's now spread to the right cavernous sinus. And so here we ended up doing radiation just to the cavernous sinus part, because he had already received the max amount of radiation to the orbit. And so then, after that photon beam radiation in October of 2022, we had another MRI, which shows that the cavernous sinus lesion was stable, but the right side lesion was even bigger.
So is this, Chris and George, is this, I mean, we're obviously losing the battle. Is there any point in being super aggressive and doing and complete exenteration and cavernous, I've done a number of surgical cavernous sinus exenterations, or is that too aggressive?
I think it's obviously worth it discussing a tumor board, doing like a PET scan, making sure there's no other foci, and then doing like a detailed MRI, make sure I understand where in the cavernous sinus it is, etc. And then if it's just localized, doing a balloon test occlusion. Now, if he fails a balloon test occlusion, whether you go away, bypass and all of that, I think that's been proven not to be helpful in most times, but I'm not sure that we have the number needed to treat for this. So that's something that's worth discussing, I think, but with the understanding that that will be sort of a heroic measure. I don't know if Dr. Shaker or WashU, UW is still doing that, but obviously one of the most
not so many radical cavernous sinus resections, but I think the writing's on the wall. The patient will possibly have a palliative exenteration in the future, but I think the patient's no longer curative based on this.
Yeah, I agree. I am mindful of the time. It's 7 p.m. and I don't want to keep us all very late. Any last minute comments or questions between the panelists? Anybody? I think we covered most of the audience questions. It's been a fantastic session. I'm sorry Maria couldn't be with us after her masterful anatomical presentation. Chris, we're mindful that you need to hit the slopes either now or later or tomorrow. Thank you for sharing this time with us. George, thank you. Great seeing you both last week in Tampa at the NASBS. To the audience, have a good night. Thank you all.
You
Bye-bye.
pleasure. Thank you.
Thanks.
Thanks.